Hey everyone, if you're getting ready for your AFK exam, you already know that facial trauma questions can be seriously tricky. So in this explainer, we're going to break down the absolute key signs and symptoms you need to nail the diagnosis on these complex fractures.
So let's set the scene. A patient comes in after some kind of accident, and their face is just, well, it's a puzzle of swelling, bruising, and pain. Now, the board exams love to test your ability to look past all that noise and pinpoint the one or two pathognomonic signs that lead you to the right answer. And that's exactly what we're going to focus on today.
We've set this up for maximum retention. We'll kick things off with the essentials of mandibular fractures, then jump into the classic Lefort classifications. After that, we'll tackle how to differentiate those tricky mid-face fractures, and we'll wrap it all up with a rapid-fire recap that's perfect for exam recall. Okay, first up, mandibular fractures. We're starting here for a very simple reason. It's the most commonly fractured bone in the face. Understanding these patterns is absolutely fundamental. Now check this out. What's really interesting here is the breakdown by location. You might instinctively think the angle is the most common fracture site, right? But look at the data. It's actually the condyle at just over 29%. That is a high-yield fact you'll want to remember. The angle is a close second, though, followed by the symphysis.
Fractures are also classified by type. You've got your green stick, which is an incomplete break. You see this a lot in kids since their bones are more flexible. A simple fracture is just a clean, complete break. Now, pay attention to these next two because people mix them up. A comminuted fracture is when the bone is shattered into a bunch of pieces. A compound fracture is any break that's open to the outside world, either through the skin or the mucosa. Two very different things. And here we have a really critical clinical concept, favorable versus unfavorable fractures. It all comes down to the pull from the muscles of mastication. If those muscles pull in a way that holds the broken pieces together, that's favorable. But if the muscles pull the segments apart, well, that's unfavorable, and it makes treatment a whole lot more complicated. All right, let's move up to the midface. When we talk about major trauma here, the Lefort classification system is really the bedrock of our diagnostic language. So let's break down all three levels one by one. First, the Lefort eye. This is a horizontal fracture that basically detaches the whole maxillary arch. You're going to see malocclusion, a mobile maxilla, sure, but the absolute crucial sign is this, a palatal hematoma. If you see bruising on the roof of the mouth, that is your diagnostic keyword for a Lefort eye. Lock that one in. Next is the Lefort 2, which is a pyramidal fracture. In this case, the whole midface, the nose, and the upper jaw moves as a single unit. There are a few signs, but the classic, unforgettable indicator is periorbital ecchymosis, what everyone calls raccoon eyes. You see that? You should immediately think Lefort 2. Infraorbital numbness is another really strong indicator because of the nerve involvement. And then we have the Lefort 3, the most severe of all, a complete craniofacial separation. The entire face is mobile. The unmistakable sign here is a dish face deformity, where the whole midface just looks sunken in and elongated. And because this fracture goes right through the cranial base, you absolutely have to check for CSF rhinorrhea, that clear fluid leaking from the nose. Okay, this is where things get really tough, and it's where exam questions will try to trip you up. High-level midface fractures, like zygomatic complex and naso-orbital ethmoid fractures, can have symptoms that totally overlap with the Lefort 3. So how in the world do we tell them apart? This table, this is your key. For a zygomatic complex fracture, or ZMC, the telltale signs are all orbital. They're about the eye. Look for restricted eye movement, especially when the patient tries to look up, and enophthalmos, where the eyeball itself looks like it's sunk back into the socket. Now, for a naso-orbital ethmoid fracture, or NOE, the signs are right in the center of the face. A flattened nasal bridge and traumatic teleconthus, which is that increased distance between the inner corners of the eyes. These specific signs are your differentiators. All right, let's lock all this in. We're going to do a rapid, flashcard-style review of the single most important diagnostic keyword for each of these fractures. This is pure high-yield gold for your exam. You ready? Okay, first one. You see bruising on the roof of the mouth, a palatal hematoma. You diagnose a Lefort eye. Simple as that. Next, bilateral bruising all around the eyes. Raccoon eyes. What is it? That's a Lefort 2. The patient presents with a sunken, elongated midface, that dish face deformity. No question, that's a Lefort 3. What if the patient can't look up properly and their eye looks sunken in?
Those are the defining signs of a zygomatic complex fracture.
And last one, a flattened nasal bridge and that widened distance between the eyes. That points you directly to a naso-orbital ethmoid fracture.
So here's the bottom line. While every one of these fractures comes with a whole collection of symptoms, swelling, bruising, malocclusion, your job is to cut through all of that noise. You have to isolate that one unique pathognomonic sign that definitively points to the correct diagnosis. That, right there, is the key to mastering these questions.
And I'll leave you with a little something to think about. Now that you can tell these injuries apart, think about the next step. Which of these fractures, with all their unique anatomical problems, do you think is the toughest one to actually fix? The biggest challenge for surgical reconstruction? It's a great way to connect diagnosis to treatment. Good luck with your studies.